Hi, everybody. My apologies if there's a bit of background noise on this video. Kids are playing outside, lovely hot day here, about 36 degrees, and been in charge of watching them. And yeah, so actually, I found a lovely X-ray that I was going to share with everybody, just so that you could be able to, just get a little bit of background to sometimes something that we do struggle with. Now, in this case, this patient was quite an obvious patient that we had, a patient with, severe limb swelling, pitting edema, raised JVP, and hepatomegaly. It came in also with shortness of breath, was known with hypertension and congestive cardiac failure, and presented to us. So, it's quite an obvious finding of congestive, or let's just say pulmonary congestion, pulmonary edema. But what I wanted to concentrate on in this one was, how do we identify? Because there's a few things that we need to look for. I mean, this could be a lot of things, especially in a lung like this, because you've got, almost a whiteout of some of the areas and things like that. So I said we'll just concentrate on some of the things that can lead you to the diagnosis. Now, one of the things that I like to do when I had a patient like this was actually to do a quick lung ultrasound to differentiate between a wet lung and a dry lung. That will actually tell you quite a bit. But I'm sure, even though many of you may have access to an ultrasound, some of you may not. So it may be important for you to actually just be able to recognize it on chest X-ray, or you may be working in another department, not the emergency department, an outpatient or a clinic or something like that. So we know we've got a patient with congestive cardiac failure. We know we've got a patient with left heart failure. And the one thing to remember is that cardiac failure is merely is a symptom. It's not a diagnosis. So, you can't say, for example, the patient is in heart failure. It's like saying the patient's in cough. It doesn't really make much sense. Saying the patient is in pain, or the patient is in dizziness, it doesn't really make much sense. You have to qualify that by being to so you have to be able to say, okay, what am I actually, looking at, and how am I going to be able to manage this patient? So in this patient, even though from the history it was quite obvious, it's quite an interesting X-ray. So let's have a look at that. So the first thing that I wanted to point out on this X-ray was, in any case, you need to have a system for looking at X-ray. So you can start with the soft tissue and then move inwards. You can see this rather large individual, a lot of adipose tissue and things like that. We're not too worried about the bony structures in this case, although in certain instances you will be. You need to look at the patient's name, make sure it's the right patient. We can see the application of the electrodes. Although they do say, I'm not sure what this one is doing over there. It may just be an error. But anyway, so in looking at the trachea, this actually gives you a good idea of what's going on, especially when you've got whited out lungs. Now, even though the superior areas are not whited out, the inferior areas are. Now, there's two possible explanations besides pulmonary congestion that can give you this. And one, of course, is a pleural effusion, and the other one is atelectasis, or lung collapse. So generally what happens with atelectasis is that you get the trachea moving towards that side. So let's say, for example, there was atelectasis of this lower lobe. We'd expect the trachea to start deviating in that direction. And the opposite would be true for a pleural effusion. So if you had a large pleural effusion, you'd expect the trachea to actually move away, which we don't have in this case, Now we look at the mediastinum. Mediastinum seems okay, but there's a loss of the aortic knuckle. And the reason for that is that we have quite a severe cardiomegaly. Now, even though we can't see the bottom of it, just going on this, you can actually see the right ventricle in this case. That's actually, it seems to be extruding a little bit over here. And if you look at the actual width without measuring, it's definitely more than 50%. So we've got an enlarged heart. So like I say, this patient did have hypertensive heart disease and did have left ventricular and right ventricular hypertrophy. And that was one of the reasons why the patient had gone into heart failure. Unfortunately, the patient's habitus was quite large and they had metabolic syndrome. The patient was diabetic as well. So there were quite a few things that were adding on to this. Now, what we can see from this, and what is quite typical. I'm going to try and draw this out. I'm not very good at drawing, but I'm going to try, is that we have what we call the batwing appearance. So I'm going to try my best to try and show you what that is. So what it means is that we've got areas of congestion over there at the top, and then you can see it sort of fades away, and then we've got it again going all the way to the bottom. All right, and you've got a similar thing on this side. So you can see that we've got congestion, congestion, congestion. There's no congestion really beyond that, and congestion again. So this is a batwing appearance, which is quite, indicative of a congestive cardiac or pulmonary congestion as well. The other thing that we see over here is that we see these large, these vessels, the pulmonary vessels here at the top, and they are quite enlarged, all right? So that's called capillization. And capillization is one of the cardinal findings in congestive cardiac failure. As I had said, we've also got a cardiomegaly that's going on over here. So I would guess that we're looking at just from about there to about there, that we've got our cardiac shadow, but it could be larger, it could be smaller. Sometimes if it's not as dense, and to be dead honest, this X-ray is a little bit underpenetrated. If it was a bit better penetrated, we could well probably see a right ventricular enlargement. One of the other things that we can see over here that also points to us that this could well be a left ventricular hypertrophy and left atrial enlargement and things like that, is a straightening of this left cardiac border that we see over there. So, that's not normal. Normally you'd expect a little bit. Let's do that in another color. Let's do it in this. So normally and remember, this is just going to be for illustration purposes. So what you would normally expect to see if we come from this side is that you'd expect to see the aortic knuckle like that, and then you'd expect to see the cardiac shadow coming like that. So this straightening that's occurring over here, it's quite indicative of left ventricular and left atrial hypertrophy, and it shows you exactly what's going on over there. Now, one of the things you can't see because it is underpenetrated are curly B lines. So curly B lines would be little lines just here at the bottom, that you would normally see on a better penetrated X-ray. But on this one, you can't really see it that well. But that is something that you would normally see as well. But even if you recognize the batwing appearance, you recognize the pulmonary vessel congestion, the cardiomegaly, you're well on your way to diagnosing the left heart failure. Now, in this case, remember the pulmonary congestion is due to hypertensive heart disease. Hypertensive heart disease is causing left ventricular hypertrophy, and we've also got left atrial hypertrophy as well. And these are actually what are leading to the so you've got a cardiomyopathy, an enlarged heart that's unable to move as well as it can. That's my little one over there. Again, what happened? What happened? What the Baba did?
Mama can't see it.
Mama can't see it. Why she can't see it? Okay, so what we're going to do about it now? Okay. Okay, all right, we'll throw it in the bin now. Okay. All right. Okay, so that was my little one. It's extremely cute. Just 2 and somewhat years old. Telling us a story about a stick that's in his little foot. Okay. So like I said, my apologies for the background noise. Yeah, so that's basically some of the signs that we do have. Now, you can have extreme pulmonary congestion, where you can have even the batwing becomes indistinguishable, or the congestion is so severe that you can't actually make it out. There are other signs that you can find out, and if you have a chance, please go and look for them. But in this particular X-ray, this is what we find. So we have this patient. This patient is in in congestive cardiac failure, they've got severe pulmonary congestion. So there's a few things that you need to remember now when treating this patient. Now, a lot of these patients may come in with low BPs and may actually be in cardiac failure. And this would also be one of the reasons because of your hypertrophy and cardiomyopathy that's associated with it. So a lot of them would have low BPs. And your first instinct, of course, would be to go ahead and give them fluids. But as you can see, as soon as you give them fluids, you're just going to, worsen that pulmonary congestion. I can tell you it's not fun for when a patient goes into pulmonary edema. It's one of the worst things that you can actually experience. These patients start frothing, their sats just drop, they become a true and proper resus. So you've really got to decide now what's your next plan of attack. And the next plan of attack normally is diuretics. And it may sound counterintuitive because a patient's got low BPs. Why am I trying to take out fluid from them? But the truth is that you have a problem now in that you have an increased afterload. So this heart is trying to push against very severe afterload. In other words, the blood that's sitting in the systemic circulation is actually preventing, the proper movement of blood out of the heart. So by reducing that afterload, you actually reduce the stretch on the heart. And as you reduce the stretch, you actually increase its contractility. Now, in the case of severe cardiomyopathies and severe failure and things like that, you can use milnirone, which is not commonly used as a first line, but it can be used in severe cases. And I wouldn't use it in the emergency department unless it was an absolute emergency. I would still go for adrenaline or one of those inotropes if necessary. But if you have access to milnirone, you can use it, and it will actually assist the patient in relieving the congestion as well as improving their it has an inotropic and chronotropic effect on the heart as well. So those are basically the things that we look at with congestive cardiac failure. But the main thing is to try and get out as much fluid from this patient as possible. So in this case, your fluid administration is extremely important. In fact, in many cases, we may only give the patient about 40 to 50 mils per hour, sometimes not even that much. It depends on their age as well. And some patients have a very decreased tolerance for any type of fluid. So you may keep them on oral fluids and diuretics, and sometimes you may need a combination of diuretics. You normally start with something like Lasix, furosemide, hydrochlorothiazide. You may even start with spironolactone if you're worried about your potassiums and things like that. And, you've got to look for anything else that may also be causing it. So the reason for the heart failure needs to be looked at. Now, in this case, we knew it, but like I say, heart failure is a symptom. It's not a disease. So it can be due to ischemia. It can be due to sepsis. It can be due to acute embolization. There's a lot of things that can cause it. And in this patient who's got congestive cardiac failure, both combined right and left ventricular failure, you've got to treat both of them at the same time and look for possible causes. So, of course, this patient would need an ECG. This patient would need all the usual workup. And of course, a BNP level would sort of guide you as to, how bad the congestion is, because as your cardiac muscle stretches, it releases more atrial natriuretic peptide. I hope I said that correctly. And your pro-BNP would also pick all of that up. So I hope you guys enjoyed this, and we'll have another one next week. All right, keep well. Bye. Sorry, that's my fault. I always forget to switch off the pointer. Okay, thanks everybody. Bye.